My name is Jennifer Herrera. I am the Vice President of External Affairs for the National Women's History Museum. Founded in 1996, the National Women's History Museum is an innovative museum dedicated to uncovering, interpreting, and celebrating women's diverse contributions to society. A renowned leader in women's history education, the museum brings to life the countless untold stories of women from throughout history and serves as a space for all to inspire, experience, collaborate, and amplify women's impact, past, present, and future. We strive to fundamentally change the way women and girls see their potential and power. I'm delighted to be here today for this really important conversation. In recognition of Breast Cancer Awareness Month in October, we're excited to talk to you today about advancements in screening and treatment of breast cancer. Today, I'm joined by an incredible panel of physicians at Kaiser Permanente who are all experts in breast cancer care. They work closely with patients and each other to coordinate the entire breast care process, from screening to diagnosis to treatment. And I'm also pleased to be joined by a colleague of mine from the museum to give some historical context to women's health. So let's start by having our panelists briefly introduce themselves. Dr. Gillis, would you like to start?
Sure. Hello, everyone, and welcome. My name is Dr. Amy Gillis. I'm a board-certified radiation oncologist.
Thank you so much. Dr. Hussain?
Hi, I'm Dr. Marouk Hussain. I'm a board-certified medical oncologist.
Welcome. Dr. McLean?
Thank you so much, Jennifer. I'm Ainsley McLean. I'm a board-certified radiologist, and I'm also a proud member of the board of directors of the National Women's History Museum. Thank you for having us.
Thank you. And then we have Dr. Kantek, please.
Hi, everyone. I'm Dr. Kantek, and I'm a board-certified plastic surgeon.
Welcome. And then Dr. Kozame?
Hi, my name is Dr. Nini Kozame, and I'm a board-certified surgeon here with the medical group.
Welcome. And last but not least of our team here, we have Dr. Sawanarat.
Yes, Dr. Pim Sawanarat. I'm a clinical geneticist and happy to be here today.
Welcome. So glad to have you. And we also have my colleague, Dr. Emma Rothberg here. Emma?
Hi, everyone. I am the Associate Educator of Digital Learning and Innovation at the National Women's History Museum, and I'm going to start us off by just sharing some information about the history of breast cancer awareness and the breast cancer awareness movement, in particular through the stories of Susan G. Komen and Audre Lorde. So when we think about breast cancer awareness, images of pink ribbons and the name Susan G. Komen often come to mind. And while physicians are intimately familiar with all the complexities involved with a breast cancer diagnosis, I want to share more about Susan G. Komen as a person, and then the poet and author Audre Lorde. So Susan G. Komen's name became synonymous with breast cancer awareness throughout the 90s and early 2000s. But who was Susan G. Komen? Though there's not much information about her personally that exists publicly, and most of what we do know comes from her charity and her sister, yet Komen's story reflects a larger shift in the history of breast cancer awareness. It is one that led to the contemporary movement to help prevent, treat, and cure breast cancer. So Komen was diagnosed with breast cancer at age 33, and at the time, treatment options for women were often limited to a radical mastectomy, which is the complete removal of all breast tissue, chest muscles, and lymph nodes. And Komen's sister recollects that she was adamant against having a mastectomy, but worked with her doctor to agree on partially removing the cancerous tissue. Despite the success of the surgery and reassurance from doctors, Komen's cancer spread, and she would go on to receive more surgeries and rounds of radiation and chemo. Throughout her treatment, Komen was concerned about the lack of information and treatment options available. And despite her 3 years of treatment, she passed away from breast cancer at the age of 36. Her sister, Nancy Brinker, founded the Susan G. Komen Breast Cancer Foundation in 1982, 2 years after Komen's death. And Brinker started the foundation, she said, to honor a promise she made to her sister to do something to stop breast cancer from taking more lives. And the Susan G. Komen Foundation remains a household name and has given billions of dollars of funds to be invested in research, advocacy, and awareness. And the foundation is often positioned as the originator and leader of the modern breast cancer movement, though historians have noted that a lot of it actually dates back to the 1970s, which leads me to Audre Lorde, who is a poet and author and she used her writing to shine light on her experience of the world as a Black lesbian woman and later as a mother and person suffering from breast cancer. A prominent member of the women's and LGBTQ rights movement, her writings called attention to the multifaceted nature of identity and the ways in which people from different walks of life could grow stronger together. She was diagnosed with breast cancer in 1977, and Lord found the ordeals of cancer treatment and mastectomy were shrouded in silence for women, and she found them even further isolating as a Black lesbian woman. Lord felt that the narratives of coping and healing she did encounter were not designed for her or her community, and in an effort to combat this silence and to foster connection with other lesbians and women of color facing the same struggle, she offered a raw portrait of her own pain, suffering, reflection, and hope in her writing The Cancer Journals, which came out in 1980. And the book won awards. Unfortunately, Lord passed away from cancer in 1992. So that's just a very brief history to get us started.
Thank you so much, Emma. Really appreciate that. To everyone that is watching, please feel free to use the chat feature to ask any questions. And we're going to dive into our physicians panel now. So, Dr. Gillis, how common is breast cancer?
Certainly, thank you for that question. I think it's a great way to start, and also hopefully to frame our discussion today about many of the advances that we'll talk about that have happened since the 1970s with the women that we were just talking about very specifically in their journey. So again, I think we've come a long way and really want to make sure that we're supporting women because breast cancer remains incredibly common. Looking at just statistics in the United States, 1 in 8 women in their lifetime will be diagnosed with breast cancer. So if we think about our communities, this touches all of our lives in terms of someone we know or personally. Breast cancer rates are increasing as well. So it's another concern since the early 2000s. It's about 1% a year increase in terms of the number of women being diagnosed with breast cancer. And although that number can seem incredibly scary, especially as we hear some of the stories about what the potential is in terms of this disease, we can also really hopefully today focus on positives, which are, again, the many advancements and certainly advancements in screening tests that we have that can detect cancer much earlier. And what we do know is that an earlier cancer at an earlier stage and early detection means much more curable cancer and better outcomes for our patients. And again, who are ultimately our friends, our family, and potentially ourselves. So although cancer rates are actually increasing, deaths from cancer have decreased during this time. Again, a credit hopefully to women getting our screening tests, early detection, and then better treatments.
Thank you so much. That leads perfectly into my next question for Dr. Sawanarat. Is there a way I can assess my risk for breast cancer through genetic testing, et cetera? And if so, how accurate are these tests? And is there a way to do it at home?
Absolutely. So actually, one of the easiest ways to assess your own risk for breast cancer is looking at your family history. So as a geneticist, one thing that we really stress is looking at your parents' generation, your grandparents' generation, including aunts and uncles on both sides of the family, both on your mother's side and your father's side. And that's information that can help inform regarding the risk for breast cancer, but also for other cancers, right? And even with that information, there might be modifications to your cancer screening that your physician or a genetic counselor could provide. For more specific, targeted risk information and more defined screening options, you might want to look into genetic testing. But it's important to know that genetic testing is not for everyone. It's not informative for everyone. And some people don't want that information. And so again, going back to your family history might be more helpful in those cases. There are so many options of ways to get genetic testing done now, from going into a lab and getting your blood drawn, getting a sample collection kit mailed out to you at home. And these are all options with testing through standard certified laboratories that provide quite reliable testing. The biggest challenge with genetic testing is that there's a lot of information that is sometimes uncertain, but when it comes down to the technology itself, it's quite reliable. One thing I should mention is that those at-home testing kits looking at genetics information from some of the direct-to-consumer companies out there are not equivalent to clinical type testing. So a 23andMe test is not going to be the same as a test that you get from a geneticist, a genetic counselor, or an oncologist.
Great, thank you so much. I want to turn it over to Dr. McLean. Why is screening for breast cancer important? And when should you get a mammogram?
So those are great questions, Jennifer. So we know that screening for breast cancer using a mammogram is the #1 way to prevent yourself from getting breast cancer and also from dying from breast cancer. So it's really the most important thing you can do. And we follow within Kaiser Permanente, the United States Preventative Services Task Force recommendations, which, as many of you may know in the audience, was recently modified and recommends screening every other year, beginning at age 40 with a mammogram. And this is in average risk patients, so it doesn't apply to the cohort of women that Dr. Sawanarat was referencing who may have increased family risks. And it's really important that you do have that screening, that you have it regularly. And we within Kaiser Permanente are participating in a study through the National Cancer Institute looking at different types of mammogram. And that's a common question that comes up if I get what's called a 2D mammogram or a 3D mammogram, otherwise known as tomosynthesis, does one or the other better? And what we always say is, as long as you get one, that's the most important thing right now. And we are participating in a national trial really looking at, is one better than the other in certain patients?
So to extend this conversation a little more, this question a little more, how is breast cancer diagnosed? And how long will it take to get your results of your mammogram?
When we are, as radiologists, making a diagnosis of breast cancer, the first step is really having you or the woman come in and you have a mammogram. And we always say it's not the most comfortable thing you've ever had, but it's really one of the most important. And we have incredible technologists who really help guide you through that process. And it involves taking several images of your breast. And then what we see as radiologists is we're looking at the images of the study you have today, and we're comparing it to your previous exams. And that's just another reason why having regular mammograms is so important, because what we're looking for is not only changes in the breast on today, but how that differs from something you may have had 2 years ago or 4 years ago. And that may raise our suspicion. So what are we looking for? We're looking for little dots of calcium or maybe little areas where the breast tissue looks a little bit more dense. Now, we know that in about 90% of women, that first screening mammogram or those first pictures are normal, which is great. So within Kaiser Permanente in the Mid-Atlantic states, we release those results to you immediately, usually within about 30 minutes, so that you can go on and enjoy the rest of your day. For 10% of women, they do end up having to come back for additional imaging, but that does not mean that you have breast cancer. So about 10% of women, you will get what we call a callback, and we'll notify you, let's come back, let's take some higher resolution images. Sometimes it's just related to the way your breast is positioned, and we'll do that. In a small percentage of those women, there may be something that we need to just take a small sample of tissue from. Mm-hmm. And again, we can offer that the same day within the office. We also are able to provide rapid pathology results. So if for some reason you do require having that tissue, our amazing breast pathologists can get those results back to our doctors within about 24 hours. So really doing everything we can to prevent waiting, because we know that waiting for results is really stressful. That's in general how the process looks.
Just one follow-up, when you were talking about 2D versus 3D, for the average person calling to make their appointment, I'm assuming they can just call and say, I need a mammogram, right? And then the doctor will determine what type to provide, or?
Yeah, so it depends on the facility, but absolutely. And like I always say, there is no wrong answer there, but it's a great thing to talk to your doctor about and kind of to make a determination of which type you want to have. And as we look, because breast cancer screening is really a national screening program, the idea of whether everyone should have a 3D mammogram is something that's being looked at very carefully. And but at the end of the day, there is no wrong answer.
Thank you so much. So turning now to Dr. Hussain, What are the different types of breast cancer? And are there preventative measures I could take to lower my chances of getting it?
Sure, great question. Breast cancer through research has really come a long way. So it's not a one disease, it's not a one size fits all. There are variations in the tissue. So when we get a biopsy result, we're basically classifying the breast cancer into four separate groups. There is the type that's called pre-invasive, where it has not spread outside of the walls of the cells, and that's called in situ cancers. And then we are looking at the hormone status of these tumors, which are markers that help us figure out the prognosis as well as treatment. So there is a category called hormone sensitive type of breast cancer. And then there is another marker we are looking for called HER2/neu. So that is the HER2/neu being present on the surface of the cells, puts that in a separate category of its own. And then we have a separate group called the triple negative breast cancer, where none of these markers are present in the cells. So as an oncologist, and when I'm looking at these, I'm already generating ideas in my head about what treatments this patient would be qualifying for, what are her future risks of developing breast cancer again. Is this going to be something we can cure, and what is the extent of treatment that we can provide? So that's sort of the groupings. And then in terms of preventing breast cancer, so this is something we discuss with patients during our primary care visits, as well as our oncology follow-up visits. Factors that have been linked and they're still being studied include factors like obesity, family history. Then there's a genetic link that may be discovered through genetic testing. And there are groups of families where the genetic mutation has not yet been discovered, but based on the family history, we know that the risk is higher. Excessive alcohol intake, excessive fatty intake, these have all been studied and linked. There is also a link to excessive estrogen exposure. So in the past, hormone therapy was prescribed to women in menopause to help with menopausal symptoms. And studies have shown that those drugs are associated with an increased risk of breast cancer. We also know that earlier onset of period and late menopause means a longer period of estrogen exposure. So that it has been associated with the risk as well. Women who've never been pregnant, that's also a risk factor. So some of these may not be in all our control, but definitely there are factors that we can control. And those are lifestyle, weight, exercise, leading a healthy lifestyle. These are all important for preventive measures that we can all take.
Wonderful. Thank you so much. And a reminder, if you'd like to ask a question, please put it in the chat and we will get to it after I'm done asking my questions. Turning to Dr. Gillis, what are my treatment options for breast cancer and how is that decided?
It's a great question. And as you can see from the different specialties represented here today, there are actually many different treatment options for breast cancer, with really the exact recommendations for an individual patient being very customized to that patient, to what may take into account their genetics or family history, but also the specifics of their cancer diagnosis that Dr. Hussein was just telling us about. So women really need to be cared for by a multidisciplinary team. At the very basic level of that includes a surgeon, a medical oncologist who can talk about medications, or even sometimes chemotherapies, a radiation oncologist like myself that uses radiation treatments. And some women may need all of our services or areas of expertise, but not all do. Again, it is definitely a customized treatment discussion and then decision with the patient based on the specifics of their diagnosis. Within Kaiser Permanente, we all work very hard to represent our different services and make sure that the patient also experiences our team, so that patients actually meet us in a multidisciplinary clinic where we all meet them. So the surgeon, the medical oncologist, and the radiation oncologist, we meet with patients actually all at the same visit to really try to save visits and speed up their path to getting information and making decisions. We also have pathology and radiology, all of these other specialties, even including support occupational therapy, working on physical therapy to keep them strong through this. We offer these clinics at least 4 times a week to really make sure that there's no delay in getting to us so that we can have these conversations early and make recommendations. I will say that in terms of all of those different options, and again, really customized, the one uniting specialty to breast cancer, and really kind of one of the mainstays though, is surgery. And so with Dr. Kantak and Dr. Kozame representing us here, it is certainly again, sort of a mainstay still of our treatments.
You know, before I do have a few other questions, but I did want to get to one, just going back to the mammogram. And this is for anybody here. What is a diagnostic mammogram? That's from our audience.
I guess I'll take that as the radiologist, although I know all my colleagues know the answer. So it's such a great question and it comes up a lot. So the word diagnostic essentially means that after you have your initial screening, which is the first time you come in and you get some images taken of your breast, we'll have you come back. And oftentimes what the radiologist does after that first image, if there's an area of the breast that they want to take a closer look at, they'll actually circle it on our monitors. And so when you come back, what the mammography technologists do, who are all very experienced in this, is they can actually almost zoom in on that area of the breast, whether it's by pressing a little bit harder on that area so we can flatten out that tissue and get a closer look, and then really just taking closer areas of that. So the diagnostic mammogram, I think of it as the second mammogram, that may be a slightly more focused, targeted exam that you have. Now, one of the things I didn't mention, which some of our audience members may have had happen, is if there's something we see on a diagnostic mammogram that we think has a very, very, very low likelihood of being anything we need to worry about, what we'll do is, instead of doing a biopsy or getting a tissue sample, we'll recommend that you come back for a follow-up mammogram. And that's also called a diagnostic mammogram because it's not part of your routine screening. And what we'll do is we'll have you come back at 6 months and at 12 months and at 18 months and then at 24 months. And if we see no change in that area for 2 years, then what we'll do is have you return to your regular screening mammograms. So then you'll come back again at your regular interval. So sometimes we use diagnostic mammograms as a term to just describe something that's anything besides just your routine screening.
That's really helpful. Thank you so much. So Dr. Kozame, what happens when a patient undergoes treatment for breast cancer? What is the procedure what is the procedure like? Will it get rid of the cancer altogether? What should a patient expect?
Thanks so much, Jennifer, and thanks for Dr. Gillis for leading our way. You know, our mainstay for our goal for treatment of breast cancer is surgery to remove the primary cancer and then testing the lymph nodes underneath the armpit to see if there's signs of cancer in those lymph nodes. And there's 2 surgeries for breast cancer. One is a lumpectomy where we just remove the tumor and a small portion of breast tissue around it, also known as breast conservation therapy. The other surgery is a mastectomy where we talk about removal of all of the breast tissue with sampling of the lymph nodes. When we look at one surgery versus the other, it's a personalized decision looking at the patient's cancer, some of their risk factors, personal choices as well, and what we think will give them the best oncologic, meaning that we're able to get all that cancer out with clear edges, and also a cosmetic outcome when taking out that cancer. Our goal for surgery is that we get the cancer out all on the first round when we do a lumpectomy. That is a balance in the operating room of knowing how large the tumor is and that we try and get those clear edges. Sometimes when we're in the operating room, everything looks like it's all normal. We work with our radiology teams. When we do a lumpectomy, we actually take a little mini mammogram of the piece we take out to see that, you know, it's in that specimen that we removed. In about 10 to 15% of chances, when our pathologists look at that area underneath the microscope, they see that there is cancer coming up to the edge of what we take out. And we do have to talk about sometimes going back in for a second surgery to clear those edges. What's involved with the surgery is that most of our surgeries, they do take place at our outpatient surgery centers that we have across the region here. Your loved ones can come back into the pre-op area with you, and then your surgeon is by your side as you drift off to sleep and wake back up in the recovery room like nothing has happened. We work with our anesthesia teams and with post-op care, and actually most patients, they recover pretty well, not needing actually much in terms of pain medicine from there. And then depending on the type of surgery that we perform, we do work with our plastic surgeons in terms of reconstruction from both a mastectomy perspective and then also from a lumpectomy if needed.
So that leads to our next question for Dr. Kantek. If you do undergo surgery, do you have to live without breasts for the rest of your life?
Fortunately, the answer to that question is no. We have a variety of surgical as well as non-surgical options for trying to sort of restore your sense of confidence and restore your chest contour. I'll start by talking about a few of the surgical options. There's kind of two broad categories of surgical breast reconstruction. The first is what we call implant-based breast reconstruction, which is just what it sounds like. It's reconstructing a breast with an implant, typically either a silicone or sometimes a saline implant. This can be done either in 2 stages, which is the most common form of reconstruction, where what's called a tissue expander is first used in order to sort of stretch the skin and make space for the eventual implant, which is then placed at a second procedure several months in the future. In some patients, this can even be done in 1 stage with what's called a single stage reconstruction, where an implant is placed at the time of mastectomy. In addition, there are some patients, again, depending on the specific characteristics of the cancer, as well as specific patient characteristics, where the nipple and areola may be preserved, and a patient does not then need a future nipple reconstruction. Next, I'll talk a little bit about flap reconstruction. So flap reconstruction is when the breast is reconstructed using your own tissue. Usually the area where we're able to get tissue to reconstruct a breast is from the abdomen. Some of the advantages of a flap-based reconstruction are that in some people, it can look more natural than reconstruction with an implant. And in particular, in patients who undergo radiation treatment, flap reconstructions are generally able to provide superior cosmetic results. However, flap reconstruction does mean a more invasive and longer surgery, typically with a longer set of recovery risks and a different set of surgical risks. In general, flap reconstruction is delayed until after any radiation treatment is complete. Some patients may also be candidates for a combination of an implant-based reconstruction and a flap-based reconstruction. This can be done with what we call a latissimus dorsi flap plus an implant. This is particularly useful in patients who have had prior radiation. Surgery in general, reconstructive surgery in general, requires a long-term time commitment. As I mentioned, it often can be multiple operations, which means not only multiple surgical procedures, but also multiple trips into the office to see a plastic surgeon, as well as management of major and minor complications that can arise, or bumps in the road, as I like to tell patients. As a result, there are some patients who choose not to undergo surgical reconstruction, and even in those patients, we do have other things that we can offer you, such as a breast prosthesis. What a breast prosthesis is it's a custom, you can think of it like an external implant. So it's a custom insert that can be placed inside the bra. And with clothing on, it can restore the chest contour on both sides. And in social settings, nobody would ever know that a person had a mastectomy. The downside, of course, to going this route is that without clothing on, one side of the chest would be flat. There are some advances that have taken place just over the course of my career, over the last decade or so, with regards to both implant-based and flap reconstruction. The first is that some patients can be candidates for what we call nipple-sparing direct-to-implant reconstruction. What this means is that a patient comes in to have a mastectomy, and in the same operation, implants can be placed, the nipples can be preserved, and a patient can wake up with 2 breasts in one operation. Now, the key with anything in surgery is proper selection of patients. So who might be a good candidate for a single stage direct implant reconstruction? In general, it's otherwise healthy women who have relatively small breasts, who do not want to increase their breast size, generally who want to stay the same size or go slightly smaller, as well as women who have limited ptosis, meaning there's not a lot of drop to their breasts over time, and the nipple position is close to where we ideally want it before surgery. A second advance that's really occurred over the last 10 to 20 years is muscle preserving flap reconstruction, or deep flap reconstruction. And this is where abdominal tissue can be used to reconstruct a breast while sacrificing very little to none of the abdominal muscle. Again, the key to this operation is proper patient selection, but in appropriately selected patients, this can be a really wonderful operation. And the third major advance is oncoplastic reconstruction. So Dr. Kozume earlier talked about how not all women need to have mastectomies. Some women can actually keep their breast and just have the tumor removed, usually with some post-surgical radiation treatment. In those women who have relatively large breasts, who are candidates for breast conservation therapy, sometimes a plastic surgeon can work in concert with the general surgeon to perform a breast reduction at the time of the lumpectomy and achieve smaller and higher breasts on both sides prior to undergoing radiation. In these operations, women who already had large breasts are able to make their breasts smaller, oftentimes give their breasts a better contour, and keep the majority of their breasts and nipples while treating their breast cancer.
Wow, thank you so much. That I wasn't aware of the magnitude of options. And that was just really fascinating to have you walk us through that. I do want to get to a question in the chat just to make sure we don't run out of time. So this one was from Facebook. Do most people experience shrinkage in the breast that receives radiation treatments? And how do you suggest one deals with that?
I'll go ahead and try to answer that as the radiation oncologist and see, the women that do need radiation. I would say that in terms of women treated for breast cancer, women have certainly the side that was treated may end up as a slight cosmetic difference in terms of the surgery that removed some of the tissue within the breast, as well as the combination for when you have radiation, so that they're not exactly the same side to side. But the vast majority of women report a good to excellent cosmetic outcome after these treatments. There will be a smaller portion of patients, and we put that in the uncommon category after radiation, that develop more of a minor shrinkage that may result in more of an imbalance longer term. And it's pretty rare that there's a significant shrinkage that really has a significant cosmetic outcome impact, but it clearly does happen. So if that does happen, and unfortunately there's no great ways for us to predict who that is, but again, it's uncommon to rare. If it does, it gets back to some of the things that Dr. Kantak had mentioned about how to regain symmetry or balance in terms of the overall cosmetic outcome. So sometimes the answer is, if the affected breast ends up smaller than the non-treated breast, that there could be an option for reduction surgery on the other side, again, regaining that symmetry, contour, and balance that we are concerned about. Again, primary goal is getting rid of this cancer, but we are very concerned also about long-term cosmetic outcome.
Thanks so much.
Jump onto Dr. Gillis's response, which I completely agree with. There are, in these patients who do have significant asymmetry, we as plastic surgeons will often see patients after they've completed the radiation. And some options we have for the radiated breast include things like fat grafting, where we can add volume to the radiated breast, as well as breast reduction on the contralateral breast in order to improve symmetry.
And I'll just highlight the importance again of really this amazing team and the colleagues that we have here that we work so closely with. And I think hopefully patients really experience that too in terms of meeting us. And it's so important to work as a team so we can get both our best cancer outcomes, but also, again, cosmetic outcomes.
So we're about at time, but I do want to ask one more question. I could ask you actually 30 more questions and feel like we're just skimming the surface, but I think this is really a really important way to close our conversation, and it can be for the group and multiple people can feel free to answer. But what does the quality of life look like during and after treatment for breast cancer?
So I'll take that because this is very dependent on the type of treatment we offer. So for many women that have the option of being treated with radiation followed by hormonal therapy, there are certain lifestyle changes that do occur due to these hormonal therapy. And when we talk about hormonal therapy, it's basically anti-estrogen therapies. So there are symptoms and changes through their life. That's part of what we do at the follow-up discussions, helping women cope with some of these lifestyle changes. And many times our women are amazing, and the survivors, they've often figured out techniques or changes they've made to their lives that can help with these. So I would go on to say it's not the worst. I mean, in the beginning, it does seem very overwhelming, but over time, coping skills, and also we may have options, medical and non-medical, complementary medicine options, alternative healthcare, all these things we can discuss and offer. The patients who do get chemotherapy, they end up with much more of a problem. Of course, you know, this is a life-changing treatment, and there could be often temporary but long-standing side effects that over time may go away. So we work with our patients, we help, and I'm going to tell you this, it's never easy, but over time our survivors do get to the end of their follow-up, do get to go back to their lifestyles and their families and jobs, and that's what we work as a team to provide.
Thank you all so much. We appreciate everyone who has tuned in. I am grateful for this really important conversation and that we were able to host it with you. For follow-up, please visit our website, the National Women's History Museum. You can find us online at womenshistory.org. And of course, for more health information like this, please visit kp.org/doctor. Thank you everyone for joining us today.